Welcome to our sonography lecture on renal pathology, part 7 of 14, renal failure for the sonographer. This lecture will cover acute renal failure, acute tubular necrosis, and chronic kidney disease. Renal failure causes both the excretory, so the urine production part of the kidney, and the regulatory function, so the part that releases hormones, controls our blood pressure, does all that stuff. It causes it to be decreased in both aspects. Acute renal failure, or ARF, is a common medical condition caused by a variety of diseases and pathophysiologic mechanisms. Acute renal failure is sometimes also called AKI, or acute kidney injury, depending on what some of those pathophysiological mechanisms are. Chronic renal failure is then seen commonly in obstructive nephropathies, parenchymal diseases, renovascular disorders, or any process that destroys the nephrons. There are 3, we'll say, levels of failure that can occur. We have the pre-renal level, where it's something outside of the kidney before the blood gets to the kidney. Then we have something within the kidney, so disease of the kidney, some sort of obstruction in the kidney. And then we have post-renal, something beyond the kidney, down in the lower urinary tract. So the pre-renal part of it really has to do with how is blood getting into the kidney. So hypoperfusion means that there's just not enough blood getting in. Hypotension means that there's not enough blood pressure to push the blood into the kidney. Congestive heart failure kind of affects both that hypoperfusion and hypotension. And then renal artery stenosis narrows the renal artery, therefore causing problems with how the blood gets into the kidney. So anything that's like blood getting into the kidney is usually a pre-renal cause for renal failure. We then can look at the renal portion of the levels of failure. And again, that's going to be parenchymal diseases, renal vein thrombosis, infection of the kidney, nephrotoxicity, or any renal mass or cysts that are affecting how the kidney works. So if any of those are causing renal failure, then we consider that renal-based renal failure. Then lastly, we have post-renal, and that's going to be anything that's down in the lower urinary tract. Maybe there's a stone stuck in the ureter. That stone is then going to cause the urine to back up into the kidney. That urine stasis up there might start to affect how the kidney functions. That's a post-renal cause of renal failure. Another one is retroperitoneal fibrosis. That is strictures and fibrotic tissue that's out in the retroperitoneum that changes how the ureters maneuver through the body, therefore possibly causing some sort of obstruction. The good news is, though, is that with post-renal, these ones are most likely able to be fixed. So of the failure levels, post-renal is the most favorable outcome. Let's go ahead and start talking about acute renal failure then. So acute renal failure is when the kidneys suddenly are unable to filter waste. And acute renal failure can develop in just a matter of hours, or it can take a few days. If it's not taken care of, it is fatal. And we see it really a lot of times in patients who are very ill and already hospitalized. It's a very common thing. They're in the hospital, they're already sick, the kidneys are starting to take a toll, they go into acute renal failure. Now, some of the clinical signs and symptoms of acute renal failure are going to include low or decreased urine output. If you've been in the hospital setting, quite often these patients have catheters in, or their urine output is at least being monitored somehow. And so if they're not putting out nearly as much urine as they should be, especially if they're getting IV fluids and drinking and doing all this, we expect there to be an equal amount coming back out. If they're not doing that, that's acute renal failure. We're also going to see the patient's limbs start to swell. The kidneys are responsible for pushing a lot of that water out of the body. If it doesn't go out, then it hangs out in the limbs. They might also experience shortness of breath, nausea, and tiredness. Now, the treatment for ARF is really going to depend on what level the failure is being caused by. So is it pre-renal? Is it something to do with the heart? Then we need to put a heart stent in. We need to get them on medication that raises their blood pressure. We need to do something for that pre-renal level. Is it something post-renal? Maybe we need to get rid of the stone, put a stent in, something like that. So the treatment for ARF really depends a lot on what is causing it. However, dialysis can give the kidneys a break if it is severely acute renal failure. Otherwise, giving IV fluid and medication is also helpful. Now, the tricky part with acute renal failure is that there typically is no change in appearance to the kidney. I don't know how many times I have scanned an acute renal failure patient. Everything looks absolutely normal. But if you think about it, there are so many causes that we can't see by ultrasound, like congestive heart failure, like hypotension, that we're not going to see the cause on ultrasound. However, if there was a cyst causing a blockage, if there's a large mass causing a blockage or causing issues, then we're going to see those, and then we can help the doctors get in the right direction for treating the ARF. Acute tubular necrosis then is another disease that causes the kidneys to malfunction. And acute tubular necrosis occurs when there's a lack of oxygen or blood flow into the kidneys. And this actually happens to be the most common cause of ARF. So the kidneys are very, very sensitive to how much blood is going through them, to how much oxygen they are getting. And the acute tubular necrosis is the result of low oxygen or low blood flow to the kidneys. Again, some of the clinical signs and symptoms are going to line right up with acute renal failure, since acute tubular necrosis is kind of under the umbrella of renal failure. The really good news about this one, though, is that this is reversible. So on ultrasound, we're going to see enlarged kidneys with very echogenic pyramids. And we've probably heard this combination before in other diseases of the kidney. The important part is that as the patient improves, those pyramids are going to start to darken up again. If we see the darkening of the pyramids, then we can safely assume that the patient was suffering from acute tubular necrosis versus something like nephrocalcinosis or MKCD. Acute tubular necrosis for me always reminds me of when my son was in the hospital. He had had heart surgery, and because his heart wasn't very strong, it wasn't pumping blood very well, therefore not moving the oxygen, not getting blood flow into the kidneys, and he actually was diagnosed with acute tubular necrosis. Thankfully, his condition did improve, his heart got stronger, his kidneys were able to heal, and that is the awesome part about acute tubular necrosis. It is the most common cause of ARF, but it's also reversible as the kidneys begin to receive the blood flow that they require. So here is an example of acute tubular necrosis. This is a transverse view of the kidney. So we can see the liver here, gallbladder up here. This is the kidney down here. So we have relatively normal appearing cortex, but we're seeing bright echogenic pyramids. And so remember, that did align up with medullary cystic kidney disease, and it also lines up with another disease that we haven't talked about yet, nephrocalcinosis, which are also going to cause the pyramids to increase in echogenicity. If we do subsequent ultrasounds on this patient and we see the pyramids returning back to normal, that is a strong indicator then of acute tubular necrosis versus other differentials. Here's the same patient in longitudinal then, again, relatively normal cortex, enlarged overall kidney size, and echogenic pyramids. Our last disease then for the renal failure umbrella is chronic kidney disease. Now, chronic kidney disease is a long-term disease progression in which the kidneys cannot filter blood. So we've talked about tons of diseases up until this point, and they all kind of cause the kidney to not function very well. And as time goes by and the kidney continues to not function well, it's going to slowly get worse and worse and worse. And that's where this chronic kidney disease comes in. What's really cool about the kidneys, though, is that they can take a lot before they really stop functioning. I think the kidney function can go down by like 80%, and the body still won't really even notice that it's lost that much function. So the kidneys are pretty resilient when it comes to diseases. But we monitor the kidneys through lab values, and we do that through creatinine and a BUN. And the creatinine level is a big one. That one tells us how well the kidneys are functioning, how well they're getting creatinine out of the body. That can be related back then to their GFR, which is the glomerular filtration rate. And that GFR tells us how much blood can the kidneys filter over time. And as that number decreases, that means the kidneys are decreasing in their function. So depending on the level of the GFR, the chronic kidney disease can be staged in stages 1, 2, 3, 4, and 5. 1 and 2 are really no symptoms. It's just probably that their lab work is coming back a little off. Very rarely are they going to even know that they're in a stage 1 or 2 chronic kidney disease. Stage 3 patients might start to feel a little bit more. They might start to have some high blood pressure along with it. They might start to have some edema along with it. Some different lab values are going to start to increase because their kidneys aren't functioning very well. That's when we kind of start seeing them on our tables too. It's not uncommon for the doctors to send patients for renal ultrasounds because of chronic kidney disease 3 and higher. Once we get into levels 4 and 5, these patients are kind of in rough shape. Definitely at level 5, these patients need to be on dialysis and they're most likely on a transplant list. Now, the complications of chronic kidney disease, again, is going to be completely how the kidney functions and of how well it's able to detox the body. So oftentimes we're going to see protein in the urine, blood in the urine, hypertension, renal vein thrombosis, and decreased filtration rates. On ultrasound then, what we're looking for is typically going to be any changes to the normal appearance of the kidney. So stages 1, 2, and oftentimes 3, kidneys look completely normal. Maybe a couple cysts, nothing too significant. Once we get into stages 4 and 5, we do expect that the kidneys are going to become a little bit more shrunken, more echogenic as they stop functioning well. So here's an example of a person with chronic kidney disease. The kidney is very small, only measuring 8.3 centimeters in length, and we can see compared to the liver how echogenic it is. This kidney most likely has lost quite a bit of its function. And that brings us to the end of renal failure lecture. Next up, we're going to talk about hydronephrosis.